In this lecture, I'll review sepsis. Here are the learning objectives along with the recommended reading. The current definition of sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. So number one, you have to determine whether the patient has life-threatening organ dysfunction, and number two, an infection has to be present. As for the incidence, it affects approximately 2% of all hospitalizations, and up to 30% of ICU patients are admitted for sepsis. It's increasing worldwide, mainly because patients are getting older, they're more immunosuppressed, we have more multi-drug resistant organisms, and we may also be able to detect it a little bit earlier based on current guidelines. The incidence is higher in the summer, and typically greater in those age 65 or older. As far as causes go, it could be bacterial, where gram-positives slightly outweigh gram-negatives, but not by much. It could be fungal, and this is actually increasing with more immunocompromised and elderly patients. And it could be viral or parasitic. A key to remember, and this is taken straight from Up to Date, is that definition of sepsis reflect expert opinion from various task forces and are not unanimously accepted. The criteria keeps changing, and nothing is going to change the fact that you are the one actually looking at the patient, so you have to rely on your clinical judgment over any criteria that's out there. There are two basic criteria, the 2003 consensus and the newer 2016 consensus, or Sepsis 3 criteria, which I will cover. It's important to be aware of both for your actual clinicals. However, I highly doubt the boards will test your knowledge on the clinical implications of one versus the other. The 2003 guidelines are divided into four categories: SIRS, sepsis, severe sepsis, and septic shock. SIRS, you must have two of four criteria, including elevated temp, heart rate, respiratory rate, and white blood cell count. Sepsis is SIRS plus a suspected source of infection. Remember, it doesn't necessarily have to be confirmed, but it should be suspected. And severe sepsis is sepsis plus end organ damage, such as elevated troponin, renal failure, liver failure, etc. And then septic shock is sepsis-induced hypotension after adequate fluids. The pros of the 2003 consensus is that it is much easier to calculate than the 2016 guidelines, which you'll find out shortly. It's also still endorsed by CMS, which is the primary payer to hospitals, so you can still use this criteria when you're documenting in the hospital. The cons, though, SIRS are very nonspecific. For instance, this picture on the right, Marv and Harry from Home Alone likely meet SIRS criteria for the last 30 minutes of the movie due to trauma, burns, all of the antics that they get themselves into. This does not mean, though, that Marv or Harry are actually septic. However, let's say one of them has a cold or some other minor infection, then technically you could say that they are actually septic. This is why sepsis is still a clinical diagnosis. You can't just rely on the criteria to tell you what the patient has. And the other con is that there are four definitions to remember. Now, the 2016 guideline, or Sepsis 3 guideline, is defined as diagnosed or presumed infection plus greater than or equal to 2 points from a SOFA score, which I'll talk about shortly. So SOFA is primarily used in the intensive care, whereas QSOFA is primarily used in the emergency department. So the 2016 consensus, or Sepsis 3, basically only has two definitions, sepsis and septic shock. It gets rid of SIRS and severe sepsis that's present on the 2003 guidelines. So the diagnosis of sepsis is, from previous, a life-threatening organ dysfunction caused by dysregulated host response to infection. An organ dysfunction is determined by the SOFA score, which basically predicts mortality. A score of greater than or equal to 2 equals organ dysfunction. whereas septic shock is sepsis plus hypotension, or a MAP less than or equal to 65, and a lactate greater than 2, despite adequate fluids. So this is the way I remember it. The 2003 guidelines are a little bit better at making the diagnosis of sepsis, whereas the Sepsis 3 criteria is better at giving the overall prognosis for the sepsis. So the pros of the 2016 consensus is that there's only two definitions to remember, sepsis and septic shock. There's no SIRS, which is very nonspecific, as mentioned before. And you get a more accurate diagnosis because the SOFA score is more predictive of overall mortality than SIRS is. The cons, though, is that it's not universally accepted. And SOFA score is much more complicated than SIRS criteria. SOFA score is also more expensive, and it's used primarily in intensive care. The SOFA score is based off of the following measurements, up to 4 points for each of the 6 categories, which equals 24 points possible. For respiratory, you get a ratio of PaO2 to FiO2, which requires an ABG. Coagulation is based on platelet count. Remember, if they have baseline thrombocytopenia, this score would not be accurate. And then liver, this is based off of bilirubin. Remember, if they have baseline hyperbilirubinemia, this would also not be accurate. And then cardiovascular, based on the patient's MAP and pressors required. And then CNS, this is based off their Glasgow Coma Scale. And then renal, which is based off of their creatinine and urine output. However, remember, if they have renal failure at baseline, this would not be accurate. So SOFA basically requires an ABG, question whether or not they're on pressors, you have to get liver function tests, a CBC, a Glasgow Coma Scale, and renal function. The baseline SOFA is 0 in patients not known to have pre-existing organ dysfunction. So if they do have pre-existing organ dysfunction, this scoring system needs to be adjusted. Organ dysfunction is defined as a score greater than or equal to 2, and this graph basically shows how mortality increases with increased SOFA score. The S in SOFA stands for sequential, which means that it is primarily used as a comparison of serial scores. It is usually calculated at 0 and 48 hours, and sometimes at 96 hours, and the differences are commonly used to predict mortality in septic patients. So if the score is increasing, you know the patient's mortality is increasing, whereas if you see it improving, their risk is decreasing. As mentioned, SOFA scores are more cumbersome to obtain, and the goal with sepsis treatment, which I will discuss here in a little bit, is to begin treatment as soon as possible. With this said, the Sepsis 3 criteria developed the Q-SOFA, or Quick SOFA score, to facilitate early identification of patients potentially at risk of dying from sepsis, primarily in the emergency department. Q-SOFA criteria has decreased sensitivity and increased specificity compared to SIRS in patients presenting to the ED with suspected infection. It's used at the bedside to identify patients with suspected infection likely to have prolonged ICU stay or to die in the hospital. It incorporates respiratory rate greater than or equal to 22, altered mental status, and systolic blood pressure less than or equal to 100. So 0 to 1 of these, they have low risk, and 2 to 3, they have high risk. So therefore, it's much easier to calculate. However, like I had mentioned, it's not widely used yet. Now, the goal of treatment is to begin treatment of sepsis as soon as possible. In the first 15 minutes, you need to assess their vitals and physical exam. You need to evaluate for end-organ perfusion. So this is where you'd be looking for altered mental status. Are they tachycardic? Are they tachypneic? Do they have decreased urine output? What's their capillary refill? This is also where you're going to order stat labs, CBC, basic metabolic panel. You may want to get a blood gas. You may want to get a lactate, or you would want to get a lactate if you're suspecting sepsis. maybe a lipase to rule out pancreatitis. You'd want to get cultures as soon as possible, blood, urine, wound, whatever's necessary, and then also coagulation studies. Now, after this 15 minutes, within the first hour, that's when you're going to want to give aggressive IV fluids. Now, this is if they can tolerate it. If they've got underlying heart failure, you probably won't be able to give them very much IV fluids. But the typical guideline is 30 mLs per kilogram within the first 3 hours, which equals about 2 to 3 liters of normal saline bolus. This is followed by administration of broad-spectrum antibiotics. This is typically based on the underlying cause that you think is going on. So if it's a urinary tract infection, you need to treat more common urinary bugs. So you'd probably start Rocephin. Whereas if it's pneumonia, you'd probably do, depending on whether it's CAP or HAP, you do Rocephin azithro versus if it's HAP, you may consider like vancomycin or vancomycin. You'd want to look at their prior cultures and look at local resistance patterns to figure out whether you need to treat for underlying MRSA or Pseudomonas. You'd also, this is one of those things, honestly, I didn't even know until I read the chapter myself, but you're supposed to treat gram-negative organisms first. So you would want to give, the Zosyn before the vancomycin. I personally didn't know that, but now I do. I'm not going to ask you guys a test question on that, though. Also, antifungals, only if it's strongly suspected or if the patient's neutropenic, then you may want to consider. And usually this is reserved for severely septic or septic shock. And then this is also in that first hour where you want to get any imaging that's necessary. Chest x-ray, CAT scan, abdomen and pelvis, chest, whatever you need to figure out what the underlying cause is. After this is where you want to go to the resuscitation phase, which is the first 6 hours. This is where you do frequent reassessments of the patient's hemodynamic status. This is where you want to keep their mean arterial pressure greater than or equal to 65, and you want to increase their urine output. So this is where you might be increasing their IV fluids if necessary. If they have persistent hypotension, this is where you'd want to consider getting a central line in the patient and starting pressors. Usually you use norepinephrine as first line. This is also called Levophed. And then you may add vasopressin if the Levophed dose is increasing. You can also add dobutamine in this circumstance, but it's rarely necessary. You can also add steroids if shock is unresponsive to fluids. Now, things to also include while you're treating a patient with sepsis is adjunctive care, such as do they need packed red blood cells, if they're actually a GI bleed or if they're anemic with a hemoglobin less than 7. Is their glucose under control? Obviously, bacteria feed off of glucose, so you want to keep this well under control and consider an insulin drip if you need to. You want to minimize sedation in these patients because that'll increase their risk of aspirating. You may consider renal replacement therapy if they've got acute kidney injury, so this is where you'd want to get a nephrologist on board if it's severe enough. Also, you need to consider VTE and stress ulcer prophylaxis. So I've stressed already VTE prophylaxis. However, in patients that are septic or, acutely ill requiring possible ICU stay, you also need to include PPI for stress ulcer prophylaxis. So after the patient has stabilized, then you'll want to consider antibiotic de-escalation. This is where you'll assess them daily to see if you can decrease or minimize their antibiotics or narrow them. You basically narrow them based off of the patient's cultures and whether they're clinically improving. You would want to get a MRSA PCR. These have a very good negative predictive value, especially when it's a respiratory cause as the culprit of their sepsis. You'd also get a procalcitonin. This is something that's become more and more utilized in my hospital, and I'm sure across the country. But basically it's used to help shorten the duration of antibiotics because it's very specific to bacterial infections. So duration depends on the underlying cause, but usually it's 7 to 10 days for most serious bacterial infections. So you'd want to consider a longer course if they have a slow response, or if they've got Staph aureus infection, or if they're immunocompromised or neutropenic. You may be able to do a shorter course, though, if they clinically improve quickly, or if their procalcitonin is low. And here are the sources I used for this presentation.